Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
Go above and beyond.
they become very good at what they do, but only
0.1%.
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
With Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Michelle Cardel. She's an assistant professor at University of Florida College of Medicine. She's in the Department of Health Outcomes and Biomedical Informatics. She's also part of the Center for Integrative Cardiovascular and Metabolic Diseases. So we're going to talk about obesity-related disease, it looks like. So, Michelle, thanks for coming.
Yeah, thanks for having me.
Yeah, tell me about your research.
So my background is in nutrition and obesity. So I have a master's degree in clinical nutrition and then a PhD in nutrition sciences. And I'm a registered dietitian. But my focus for the last 15 years has really focused on obesity. What are the social and environmental and behavioral contributors to obesity? And then also developing healthy lifestyle interventions for adolescents with overweight and obesity.
So you focus on adolescents, or you focus on all people? Like, is the focus more obesity, or is it more adolescents with obesity we're facing it?
So my research has spanned young children, adolescents, as well as adults. So obesity in general is kind of my area of expertise. But right now I'm very much focused on adolescents because I have a 5-year NIH grant to develop and implement this healthy lifestyle intervention for adolescents.
Yeah, so for adults, you can tell them, do this, do that, eat this, don't eat that, etc. For adolescents, do you appeal to them? Do they have to be on board, or do you appeal to the parents? Like, what's the dynamic look like?
Yeah, so we have done a ton of formative work to basically find out the very questions that you're asking. So before we started even working on the curriculum, we did a full year of formative work. We did 10 focus groups with adolescents with overweight and obesity to identify what are their perceived barriers and facilitators to weight loss and to a healthy lifestyle, and then what is it that they want in an intervention. And some very clear themes emerged from that data. One, it's that adolescents want the option to have their parents involved in these interventions, but they don't want it to be required, because some adolescents report that their parents are very helpful and very supportive in helping them achieve their lifestyle-related goals. But others spoke about how their parents are actually a hindrance to achieving these healthy goals. And they often recognize that their parents are well-intentioned and the parents want to help them. But by doing things like making comments about their weight or what they're eating or their physical activity or lack thereof, that it actually induces a great deal of shame and guilt within the adolescents that doesn't make them want to move forward in these changes. And so they've asked for quite a bit of autonomy. So we do a 6-month intervention, 15 sessions over that 6-month period, and they're an hour and a half each. And we invite the parents to attend 3 of them.
Have fun, and I don't know, maybe it's the same for everybody. Until you ask them and probe a little bit, they probably don't think about it in terms of that with goals. They just have wants.
Yeah, so that's what was so fun about doing these 10 focus groups, and then now having actually implemented the intervention over the last year and a half or so. The adolescents are very clear on what they want, and they are. It's such a joy and a real privilege to get to work with these teens because they're incredibly insightful. I feel like they're much more advanced and mature than I certainly was at their age. But yes, definitely have clearly identified goals. We talk a lot about our values and the difference between values and goals. Goals are something that we can achieve. I can set a goal of I'm going to walk for 30 minutes, 5 days this week, and I can achieve that and I can move on to the next one. Whereas values are something that are basically our compass or our North Star that are ever present and ever guiding us through our life's journey and our decisions and our day-to-day choices. And so we do a pretty deep dive with them into their values. What are their values? And then how are those values going to help drive them and keep them engaged, not just throughout the 6-month intervention, but beyond, over the course of their life. Our hope is that through this program, they're learning the skills and strategies needed to maintain a healthy lifestyle over the long term.
Well, what are some of them? You said they're very clear. Mm-hmm. So I would bet you that you were surprised at the clarity of the goals. And then what are they? What are some examples?
Yeah. So, I mean, everybody had very different ones. Some of them originated from more medical-based goals, in the sense of some of the adolescent girls with obesity, for example, talked about a desire for overall health and wellness. So one of those things that was a barrier for them to getting that was their breasts. And so many of the girls in our program have actually expressed a desire to acquire breast reduction surgery in order to live like a more full life and a pain-free life. You know, at the very young age of 16, 17, 18, it's already become a barrier for them and has affected their quality of life. And so I often hear their value system being really focused on, overall quality of life, being able to be a role model for their family. And that can be for younger siblings. It can be even for their parents. Things like a love of travel or adventure or exploration, and recognizing that, sometimes their weight or their health can get in the way of that. We've talked about a lot of mountains to hike and places to go. So those are some of the ones that stick out to me, but education is also one. A lot of these kids have big dreams and big goals, and they really see that a journey to a more healthful lifestyle as being a key component to helping achieve these values over the long term.
Well, quick question here for girls and for women that are, obese. Does that go into the breast tissue a lot? Like if they lose weight, they become more of a non-obese weight. Does their breast size come down or does it stay?
Well, there's actually huge variability in that. So it really depends on the person. So the reason why a lot of these girls want to do our intervention is because they've already gone to a surgeon and the surgeon has told them, I'm happy to do the breast reduction surgery for you, but you have to get to a certain BMI. Otherwise, there's a significant risk on the operating table. So we need you to get down to this, whatever BMI it is that the surgeon deems, in order to ensure the highest level of safety for you when I'm operating on you.
Oh, but sometimes if they lose significant weight, their breast size still won't change, and sometimes it will.
Exactly.
I wonder what governs that. That's interesting. Do people see that with other parts of the body? That some are just stubborn and tend to hold on to extra adiposity longer?
Yes, absolutely. So there's a huge genetic and heritable component to not just body size and weight, but also body shape and fat deposition. So where we tend to store fat is heavily genetically determined. I'm sure you've heard about the different types of quote unquote shapes, a pear shape versus, kind of an apple shape, things like that. And so for some people, even when they lose a significant amount of weight, they're what they call kind of quote unquote stubborn fat sometimes does still remain.
Yeah, I've seen like in men, sometimes they have a big gut and the rest of them skinny. Yes, and then some are more evenly distributed, and women it seems like in the thighs and butt area. So interesting. What about the protocols, the weight loss protocols that you're developing? Mm-hmm. Anything you think that works particularly well?
Yeah, so the therapy that we've developed is based on something called acceptance and commitment therapy, or an acceptance-based therapy. So I'm sure you're familiar with cognitive behavioral therapy, which has shown to have modest to moderate results in terms of weight loss. And cognitive behavioral therapy is now kind of the field of psychology is deemed a second wave therapy, whereas these acceptance-based therapies are being deemed kind of a third wave of therapy and intervention. And so the preliminary work in our intervention we've seen some preliminary success. We haven't done the large, fully powered randomized control trial that we really need to determine efficacy or effectiveness, but hopefully we'll be able to acquire funding to do that soon. But the adult studies that have done this, in adults, we're pretty happy if we see, about 5 to 8% body weight loss over a 1-year period. And studies using acceptance-based therapy from Drs. Evan Foreman and Megan Butrin at Drexel University have shown about 13.3% body weight over a 1-year period. So that's even reaching levels of like pharmacotherapy intervention or anti-obesity medications. So I think there is some really promising data out there. And I hope that we have the ability to pursue more research in this area of acceptance-based therapy.
What does that mean, acceptance-based therapy?
Yeah, so acceptance-based therapy focuses on a variety of factors, including things like self-regulation skills, mindfulness, as well as acceptance of uncomfortable internal experiences. And we utilize things like willingness to identify, what are the experiences that we're having, focusing on accepting them, and basically choosing to do these difficult or uncomfortable behaviors anyway. So think about, weight loss is not as fun, quote unquote, as, maintaining the behaviors that can keep us at a higher weight. So it is way more fun to watch Netflix and sit on the couch than it can be to go on a walk, or, it's more fun, quote unquote, to eat pizza than it is hummus and carrots, or, an apple and a cheese stick. And recognizing that there is discomfort and uncomfortable internal experiences that occur during the weight loss process, but choosing to engage in those behaviors that help us reach our goals and drive us towards our values, choosing to engage in those behaviors anyway.
What are some specifics? Like, I don't know, the person would feel hungry and they want to eat something and they can't, or
Sure. So,
do they feel like they're doing everything right and other people are just eating whatever they want and they're thin and they're not? I mean, like, what do you mean?
So think about like a cold winter morning. Your alarm goes off at 6 so you can go to the gym before you head off to school or work. And you wake up and you're so cozy in that bed and you don't want to get up, and you think, you know what? It's fine. Like you're inside your head, you're saying, I'm cozy. I don't want to get up. Using acceptance-based therapy would be recognizing, okay, I'm having the thought that I don't want to get up because it's cold outside and I'm cozy in bed. And acceptance-based therapy would teach you the willingness to say, you know what, even though I'm having this thought and I'm having this urge to stay in bed, I made a commitment to myself and to my values to engage in these healthy behaviors. And I'm going to make the choice, even though I'm having these thoughts, to get up, put my sneakers on, and go to the gym as I promised myself.
Yeah, that wouldn't be easy to do. Everyone would love to just stay in bed and it's warm.
Right. Of course.
Well, what factors external to the person appear to be most important? You talked about parents being supportive or being dismissive or making comments, but what other factors? If the kids are in school or with their peers, I mean, what seems to impact them most?
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
In our program, I don't have the data to support this. We haven't really assessed this in our data analysis yet, but it appears to me the peer support that they're receiving from the intervention is going to be a significant predictor of their success. I think the participants really express that they feel really supported as part of the program. And that I think helps with continued engagement and retention. Other things that could potentially play a role are things like the resources available to the teens. We have some data to suggest that individuals in lower resource settings or lower social status settings may not have the same access or ability to engage in some of the health-related behaviors that we recommend in the intervention. So I'll be very interested to see if this intervention is effective across like the socioeconomic spectrum, for example. But because we're still so early in the research in terms of the teens, I don't have the answer for you that way yet. In terms of the adults, they did not see that the effects of the intervention differed in terms of race or sex or socioeconomic status. So I hope to see the same thing in our intervention.
So, I mean, in general, what do you see as necessary for someone to lose weight and keep it off?
Yeah, that is an excellent question. It is, it really has to often come down to this recognition that obesity is a chronic disease, and it's something that people are going to have to kind of work at for the rest of their life. I don't see obesity as being any different than asthma or diabetes. While you're eating a healthy diet and you're engaging in physical activity and you're taking your medications, your diabetes can get under control. But that diabetes never goes away. You're never cured from the diabetes per se. And so similarly with obesity, it has to be a lifelong commitment. And one of the things that I see that differs in obesity is unlike the way that we treat obesity in medical, unlike the way we treat diabetes or asthma in medical care, where it's treated as a true chronic condition and care is available and accessible and paid for from our insurance companies throughout your life course. Obesity is often seen as kind of a one-time thing, or, okay, you're going to lose this weight in the next 6 months and then, good luck. We would never treat any other patient with chronic disease in that flippant manner. So I think changes need to be made from both an insurance perspective in order to cover obesity care, but also within the medical community to recognize that our patients with obesity need access to care for their chronic condition, just as we would with any of these other chronic diseases.
If someone thinks, I haven't heard someone say, I have obesity, meaning like it's like a disease. Mm-hmm. But if they do, I don't know, it just seems like they may, like with other diseases, they may externalize that, oh, this disease happened to me. It wasn't my fault. And now I have this disease. And it seems like, I don't know, that thought pattern could lead you to, well, I'm just going to take medications and nothing I can do. It just seems to less self-agency. I don't know. Is that right? Or you think that's a mistake to think that?
I certainly think that recognition that obesity is a disease is an important component because, we are very much as a society, very stigmatizing. Nobody can look at you and know from looking at you that you have diabetes or asthma. And with obesity, it's a disease that's worn on the outside. And when people look at you, they can see that. So the amount of discrimination and stigmatization that is, given to people with obesity is incredibly harmful, not just for their mental health, but also for their physical health. And so I think we really need a paradigm shift in how we look at obesity. The data is very clear. I mean, up to 70% of our body size and shape is heritable. And I don't want that to sound as though it's deterministic, that simply because, 70% up to 70% of our condition may be attributed to genetic factors. There's still very much a component where we can have a say or play a role in what those outcomes can be, but also recognition that there is a great deal of diversity in body shapes and sizes, and that we as a society need to stop equating body size to health. That we really can't determine anything by a person's body shape or size, and at the individual level, determine health outcomes. That's why we really advocate for much more thorough, social history, medical history, and assessments when our patients with obesity come into the office, and really start off with asking the question like, why did you come in and see me today? Tell me about that. And then if it comes up that, whatever it is that they're seeing you for may be related to weight, then broaching the topic as permission. Is this something that you would like to discuss with me? And if so, what are the words or terminology that you would like me to utilize? And these are the steps that we now have to take, because the experiences that people with obesity have been so stigmatizing and so discriminatory, that, many people don't even want to go see healthcare providers anymore, because that's been some of the source of the worst stigmatization and discrimination. And so we're as a field, we're very much trying to move away from that.
Well, what's some examples? Like people going to doctors and the doctors say, hey, you need to lose weight. You're going to have this, that, and the other happen. And that's it. They just throw a prescription at you or just leave, or like what kinds of things have happened?
Yeah. So in some of my focus groups that we've done with the teens have reported that the physicians have made comments that are quite derogatory towards them, or making assumptions about them simply based on their weight. And then what's worse is then when they're diagnosed with overweight and obesity, the provider says to them, okay, now you have to lose weight, eat less, move more, see you in 3 months or 6 months. And, to bring it back to the treatment of other chronic care conditions, we would never diagnose a patient with asthma and then be like, okay, you have asthma, try to breathe more. Good luck. See you in 6 months. We really have to provide evidence-based care and resources for the patients in order to facilitate change. It's very difficult to lose weight and maintain weight loss without medical supervision or evidence-based treatments available. And I know it's a struggle. Providers have very limited time that they can see patients, and I'm confident that they're doing the best they can with the resources that they have available. But that suggests to me that we need to make changes, because what we're doing now and just sending people on their way and telling them to eat less and move more, if it was that simple, I wouldn't have a job.
Yeah, no, that's true. That's true. Yeah, I remember going to a doctor, I don't know, right, 15 years ago. And, I've always been heavy. And he was lecturing me about, what to eat, what to do and all that. And I looked and I'm like, this guy's just as big as I am. What's he talking about?
Yeah. And it's very difficult. It's not, I think one of the biggest misconceptions out there is that obesity is a reflection of a lack of willpower. In my experience with patients with obesity, the exact opposite is true. I don't think I've ever had a patient with obesity come to my office and not have basically tried, every diet in the world. Atkins diet, paleo diet, ketogenic diet, vegan diet, like they've tried everything. And it's not them that's failing. It's the system. It's the message that this is easy, that this is simple. All you have to do is quote unquote, eat less and move more. And what there isn't enough recognition of is the very real and very strong physiological drivers that push people to eat more when they're losing weight. Our bodies are very good at weight regulation, and they want us to stay at that. They want us to maintain our weight, not lose weight. And so recognition that obesity is neither a crime nor a character flaw, and it is not a reflection of an individual or their willpower or character at all.
So what do you see as the future of, obesity care? What's the picture look like for you?
So I think we're moving along really well in 3 different treatment modality domains. So one is the kind of more behavioral lifestyle intervention. And so that generally tends to be kind of the first line of treatment for individuals who are non-responders to lifestyle behavioral intervention. There's now some pretty great anti-obesity medications that have been developed that we have approval for in adults. They're starting to try and get FDA approval for some of these medications for adolescents. And the preliminary data is very promising. And then for individuals who do not respond to lifestyle and or pharmacotherapy intervention, bariatric surgery is an incredibly effective treatment for obesity. And for individuals with obesity and diabetes, sometimes we're seeing complete remission of diabetes within even 2 weeks. Even in the absence of significant weight loss, there's only so much weight you can lose in a 2-week period, but complete remission of the diabetes. And so currently, bariatric surgery is the most effective treatment that we do have available currently. So I hope that we continue to move in the area of personalized obesity medicine and identifying what are the factors that are going to make somebody more likely to respond to a certain treatment. And so we can get them on the right treatment course faster to get them to, the health that they want to achieve.
Well, very good. Michelle, what's the best way for people to find out more about your research as you get along?
I'm very active on social media. You can find me on Twitter at Michelle Cardel, on Facebook at Michelle Cardel, and on Instagram at Dr. Michelle Cardel. I do a lot of science communication and put all my research as well as the findings and translation of the research of others in those spheres. So if you're interested in obesity or nutrition, please go ahead and give me a follow and let me know what you think.
Well, very good. Michelle, thanks for coming on the podcast. I appreciate it.
Absolutely. Thanks so much for having me.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.